Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. It's my pleasure to welcome you to our NIH webinar series on the research that can advance our progress toward hepatitis elimination. Today, we will be co-convening this with the National Institute of Minority Health and Health Disparities, and for our webinar to look at leaving no one behind, interventions that address systems and structures to reduce hepatitis C virus disparities. And you see the speakers and panel here on this slide, and you'll be hearing more information about them and hearing from them over the next hour and a half. Next slide. So welcome everyone. It's great to all get together and look at how we can achieve health equity and overcome disparities to achieve goals for hepatitis elimination. Just a little bit of housekeeping. We really encourage you to submit questions in the Q&A feature of the Zoom system. And we'll seek to answer those questions by presenting them orally after the presentations or perhaps during the discussion, and as well as asking the speakers to comment on them, after their presentation is over. The webinar is recorded. It's posted on the Coalition website at globalhep.org, as are the slide presentations, as well as the synthesis that summarizes the highlights from the presentations and discussions, and all of that's available, on our website. This is our third year of co-convening these webinars with NIH, and our third one with this institute. So we have a wealth of information from NIH that's available on our website. This series is brought together every year by an organizing committee that represents many of the institutes and offices within NIH, as shown here. I want to particularly thank my co-chair, Betsy Reed-Canole, who's a program officer at NCI, that co-chairs this with me, and Carolyn Wester, from CDC, who's on this panel as well. Next slide. As I mentioned, we have all of this information is available on our website as a information resource. And we see this as an important way of getting the information out regarding research that can advance progress toward hepatitis elimination from NIH in a very open and transparent way. So I really encourage all of you to take advantage of this wealth of resources that has been brought together by NIH through this webinar series. These are the webinars that we've had with this institute before to look at disparities. Disparities is a very big issue for hepatitis, as certain populations have high prevalence and are at highest risk for hepatitis B or hepatitis C. And that's what we're going to continue to explore in this edition of this webinar series with today. And again, this is my program, and I'll turn it over to my colleague, Rena Das, to kick off the program. Rena?
Thank you, John, and welcome everybody. My name is Rena Das, and I'm the Division Director for the Division of Integrative Biological and Behavioral Sciences at NIMHD. So on behalf of the Planning Committee at NIMHD, I want to welcome you all for this webinar on hepatitis elimination. We have a great session planned with the speakers that you see, 3 speakers and 2 panelists. And basically, the objective of our session is to highlight some of the ongoing research that focuses on HCV elimination efforts in at-risk and underserved populations that experience health disparities, And we would like to see if we can emphasize some of these systems and structure level factors and provide examples of some interventions that have shown some good results, and communicate best practices and research needs to improve HCV intervention among populations that experience health disparities. Basically, some innovative ways to intervene on some of the upstream social determinants of health that are very important. So to start us off, we are very delighted, and I'm privileged to introduce our Deputy Director of National Institute on Minority Health and Health Disparities, Dr. Monica Webb-Hooper, who will provide some opening remarks. Dr. Webb-Hooper, please take it away.
Thank you very much, Rina, for that introduction. And I want to welcome everyone. I'm really delighted to be with you and to help open this really important webinar. We know that disparities in hepatitis C are of high interest to NIMHD, particularly intervention research toward reduction and elimination. So I want to offer a few thoughts as we move into the webinar. When we talk about health disparities, they're not just any differences between groups. Key points are that they are by definition preventable or avoidable and are rooted in disadvantage, and they're modifiable. We see racial and ethnic and socioeconomic status as sort of the two pillars of disparities and that drive them, which may intersect with other characteristics such as gender, sexual orientation, geographic location, and other characteristics. Here are the NIH designated US populations that experience health disparities. These groups include all racial and ethnic minoritized groups, socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minoritized groups. Hepatitis C is a viral infection that causes liver inflammation, sometimes leading to severe liver damage. The virus spreads through contaminated blood, and still about 40% of people with hepatitis C virus don't know that they're infected, mainly because they have no symptoms, which can take decades to appear. The development of direct-acting antivirals, or DAAs, which was a huge scientific and medical advancement almost a decade ago, which can cure hepatitis C in more than 95% of infected people. And hep C liver transplants are down about 50%, which is great progress. Now, medication reach is still an issue. It's more limited than it should be, reaching only a fraction of the people who are infected. And we're still dealing with about 15,000 deaths in the US from hepatitis C complications every year. The virus is spread primarily by contact with blood and blood products. There are a number of risk factors, right? And injection drug use being the most common one currently. That was a difference from the past. I think the point here is that many of the risk factors are preventable, or they have related issues that are preventable, which does present opportunities for prevention and intervention efforts. There are racial disparities in hepatitis C prevalence, with the highest prevalence among American Indian and Alaska Native people and rural communities compared with urban populations. And also we see greater prevalence among females. And when you look over a 20-year period, all racial and ethnic minority populations have had greater mortality rates relative to white persons, which is that blue line toward the bottom of the figure. If you look between 2016 and 2020, the death rates have started to decrease among Latino, Asian, and Pacific Islander and Black persons. Unfortunately, and in contrast, we've not seen this trend among American Indian and Alaska Native persons, as mortality has steadily increased and is about 3 times greater compared with white persons. Chronic hepatitis C associated deaths did increase in 2020 compared to 2019, and were higher among American Indian, Alaska Native, and Black or African American persons compared with white persons. Socioeconomic disparities exist in terms of direct acting antiviral use, with less use among people with lower income levels related to access issues. There's also a higher burden of liver cancer among racial and ethnic minority populations, as well as a lower likelihood of receiving guideline concordant screening for hepatocellular carcinoma among Black or African American patients and patients living in rural locations. So there's a lot of work to be done, and we are pleased to see that attention to what needs to happen for hepatitis C elimination has the attention of the White House, who proposed a 5-year program on this. Also, we're delighted that our program officials at NIMHD recently published a scoping review on this topic, including highlighting opportunities for interventions to reduce disparities. Now, given that the risk factors exist and that many are preventable and that there is highly effective treatment available, it's critical that these advances in screening and treatment benefit all populations and that prevention is a significant focus. So we encourage investigators to consider multiple factors as they propose health disparities research in this area. This evolving NIMHD research framework that you see here, we think it's an excellent guide for research, and I think of it also as a hypothesis generator. Finally, I want to mention that NIMHD continues to support meritorious research on liver diseases and cancer. We've had a specific funding opportunity since 2017, which is also supported by NCI, the National Cancer Institute, and was reissued in 2020. A new concept on this topic was approved at our February 2023 council, so stay tuned for the release of an upcoming funding opportunity. So I just thank you again, and I'll turn it back over to Dr. Das.
Thank you, Dr. Hooper, for that very inspiring presentation. So now that you know how NIMHD is engaged in this space, let's get started with our speakers. Our first speaker for this session is Dr. Brian McMahon. He's a clinical liver specialist and director of the Liver Disease and Hepatitis Program, the Alaska Native Medical Center in Anchorage, Alaska. He has directed the vaccination programs in Alaska Natives that have reduced the rates of acute hepatitis. Today, he's going to present on eliminating hepatitis C infection in urban and rural Alaska, unique challenges and progress to date. Dr. McMahon, take it away.
Thank you very much, Dr. Dawson. Hope you can all hear me. Can I have the next slide, please? The next slide, please. So Alaska is quite a large state, 2.5 times bigger than Texas, but it stretches, if we impose it on the lower 48, from Sacramento to all the way to Savannah, Georgia, from east to west, and from Duluth, Minnesota, all the way to Savannah, Georgia. So it's an enormous area to cover. Next slide. So the Alaska Native Liver Disease and Hepatitis Program was established in the early 1980s, first tackled hepatitis B, and we are hepatitis B, the only endemic area in the United States is in Western Alaska, and we have stopped transmission by mass screening of the population and vaccination, and introducing a newborn vaccination for hepatitis B in the early 1980s. And we've also linked all of the chronic persons with hepatitis B to care since that time. But hepatitis C is a much bigger challenge for us at this point. And we started working in hepatitis C, doing research in hepatitis C back in the 1990s. And we started out with a 10-year center grant with University of Washington, followed by an R01 grant from University of Washington for 5 years. And then since then, we've had CDC 5-year grants, and Dr. John Ward, when he's the director of the Division of Viral Hepatitis at CDC, was very instrumental in helping us with these grants and also giving us a lot of guidance for the work that we've done in hepatitis C. So the first thing that we did in hepatitis C was to look and see what was the effect of transmission or what was the effective outcome of hepatitis C prior to the development of direct-acting antiviral drugs. We offered patients that we found with hepatitis C interferon, but most weren't interested. And those who started interferon oftentimes dropped out or didn't finish. And then the sustained virologic response rate was only about 40%. So those people who didn't receive interferon or didn't get an SVR were followed prospectively. They had a liver biopsy when they entered to see if they should be treated or not, and they were followed prospectively for almost 8 years. Next slide. And I'll talk about that a little bit later. But when 2014, when the direct-acting antiviral drugs became available, then we started offering those drugs to every person, literally every person who had chronic hepatitis C, to treat them and get them cured. We also purchased 2 FibroScan units. One was in our clinic, our liver clinic in Anchorage. The other is a portable unit that we take out to the field when we go out to do field liver clinics. So after that, we rarely did liver biopsies on patients with hepatitis C. So we then received a number of, again, from the CDC primarily, grants to study the outcome of treatment of hepatitis C. So we worked with our partners statewide and to try to eliminate hepatitis C. And we wanted to compare the response and outcomes in relation to liver-related death, liver failure, and hepatocellular carcinoma in this cohort that we had recruited prior to the availability of direct-acting antivirals, and then after direct-acting antivirals were available. And I should mention that every one of those persons who didn't get a direct-acting, weren't treated prior to 2015, that were in that first cohort, all were offered DAA treatment, and most of them actually took it. Next slide. So here's what we've accomplished so far. We've treated over 1,200 persons all over the state, and 97% SVR. There's been 32 known reinfections. So fairly successful start. Next slide. Now this is the problem. If you look at this map and you see that in the center of the map in Anchorage is where we're located. And each one of those bigger dots is where there's a hospital or a clinic located. But the 200 little dots are small little villages where there's no licensed provider. And the care is provided in these villages by community health aid practitioners. They're indigenous people who receive a 16-week course and have a manual and have a computer available. And they're the ones who see the patients in these communities. So if we're going to eliminate hepatitis C, we have to be able to work with these community health aid practitioners and help them to learn how to diagnose and treat hepatitis C. Next slide. So the other problem that we have in Alaska is that hepatitis C knows, as everybody knows no racial or ethnic boundaries. So if we're going to eliminate hepatitis C in the Alaska Native population, we have to eliminate hepatitis C in the entire state of Alaska. So we formed a group called the HOG, the Hepatitis Alaska Statewide Working Group. We meet quarterly. We met yesterday. And these are the partners you can see in the HOG and are very actively involved. And we set up educational programs around the state to train licensed providers on how to diagnose and screen for hepatitis C and how to treat hepatitis C. And so the goal of the HOG is to eliminate both hepatitis C and hepatitis B in Alaska. Next slide. So I want to go back and show you the outcome of those 412 patients that we did liver biopsies on before DAAs were available. Some took interferon, and then all of these people either failed interferon, refused interferon, or quit while they were treated. So 2/3 of those patients had only mild fibrosis, 20% had severe fibrosis or bridging fibrosis, and 10% had cirrhosis. Next slide. So what was the outcome of these patients in terms of end-stage liver disease, hepatocellular carcinoma, or liver-related death? And this is published in Hepatology in 2017. Next slide. So the first table shows you the outcome in the patients with end-stage liver disease. At the beginning, when they had their liver biopsy, 150 of them had mild disease. After 10 years, 8.4% developed liver failure. If they had moderate fibrosis at the beginning and liver biopsy, by the end of 10 years, 20% developed liver failure. With severe or bridging fibrosis, 31% at 10 years developed it. And if the initial biopsy showed compensated cirrhosis, that group didn't live long enough that we could actually do a 10-year follow-up because 3/4 of them had either developed liver failure or at the 7-year period. Next slide. Looking at the outcome of hepatocellular carcinoma, a similar picture, only 1% of those with mild disease at 10 years, 5% of those with moderate disease on biopsy at 10 years later, and 8% of those with severe disease, but a third of those that had cirrhosis, compensated cirrhosis by 7 years developed hepatocellular carcinoma. Next slide, please. And as far as either liver-related death or having a liver transplant, you can again see that only 1% if they only had mild or no scarring at biopsy versus 3% if they had moderate versus 12% if they had severe versus about a quarter of them if they had compensated cirrhosis at the time of their biopsy 7 years later. Next slide. So one of the things that we're doing right now, and we obviously are in the middle of this study, and I can't really show you the results, but what we're doing is we're looking at those patients who have received DAA and were cured. And we're doing the same thing, only we're using FibroScan to follow them every year. And we're comparing the adverse outcomes of hepatitis C patients to that group that I just showed you of untreated patients. And we're looking for other factors that might influence what happens to them after they're cured, including demographic factors, social factors. They all get an audit C alcohol test every time we see them to see if there's alcohol is a factor. And we also look for NAFLD in these patients using the standard techniques for diagnosing NAFLD. Next slide. So we have over 1,000 consented patients in this study. We take care of anybody who lives in rural communities are cared for by the Alaska Native Tribal System. It's a tribally owned healthcare system. So if you're not Alaska Native, you still get taken care of by them. But if you live in an urban area where there's hospitals and private providers, then you're not seen in those areas. We've had over 1,000 are still alive and are actively still in our study. Next slide. And these are the clinical features that we're looking at. NAFLD, over 100 have NAFLD, over 300 have diabetes or prediabetes. So far, we've seen 49 patients with hepatocellular carcinoma. We have a few with HIV. They're going to be dropped out of the analysis. And these are the outcomes thus far: liver transplant 11, decompensated cirrhosis 11, and cirrhosis 46. Now, these are, again, all patients that have been treated with DAAs and reached an SVR and are followed for at least 5 years after that, or will be followed for 5 years after that. Next slide. So one of the big problems that we have had is that although we've diagnosed a lot of Hep C, we're having trouble getting everybody treated because even though we offer the drugs for free, sometimes they don't come in to get it and we can't find them. Next slide. So we're hiring patient navigators to begin to go out and try to find, again, with CDC funding, go out and find these people that haven't been treated, and also to enhance screening at places where people with high risk for HCV go to. That includes homeless shelters, needle exchange programs, pre-clinics, and opioid rehabilitation programs. And in these programs, we're offering screening both to Alaska Native people and non-Native people. Non-Native people will be referred to clinics that care for them, and then Alaska Native people will come into our system to be treated. Next slide. So one of the really unique programs, I might just say that so far some of the things that have been exciting is that one of our tribal organizations, so there's 12 tribal organizations in Alaska, and one of them has placed a prompt in their computer that pops up every time someone has a blood draw if they've never been tested for hepatitis C. And it tells the person who's going to draw their blood, ask them if they want to be treated for hepatitis C, and if they say yes, that's added onto the blood test. Another tribal organization is really aggressively working to screen everyone and feels they'll reach the 2030 goals that are set out by CDC and WHO by 2027. And another tribal group is using pharmacists to manage and treat the patients with hepatitis C once a licensed provider has written the medication and done a physical exam. And then they're completely taken care of for the rest of their treatment and follow up by the pharmacist. Next slide. I think one of the most unique things that we're doing right now, again with a grant from CDC, is we're training these community health aid practitioners, the barefoot doctors in the 200 villages, to screen with a rapid fingerstick test for hepatitis C. If it's positive, draw blood. That's one of the things that they do, and send it to our lab. And if they're HCV RNA positive, then one of our liver providers works with the health aide and the patient via telemedicine, so they don't have to leave their community multiple times to fly 100 or 200 miles to the nearest place where there is a licensed provider. These villages are not obviously connected by roads. So we've conducted 2-day programs to train these community health aid providers how to do this. And then again, we are using telemedicine. And we've trained providers in 11 communities thus far, and then we'll try to expand this program over the next few years. Next slide. So in conclusion, hepatitis C virus infection is present in an estimated 3 to 5% of Alaska Native people. We're actually finding in some of these small communities, it's closer to 10% that have hepatitis C. The Liver Disease and Hepatitis Program has been doing research in hepatitis C since the 1990s, supported by NIH and CDC. We're working with the state of Alaska, and we also, I forgot to mention, have a branch of CDC right on our campus. There's about 35 people that work there. They're very involved, obviously, as well as the Division of Viral Hepatitis. And we're working with them in the state to try to implement universal screening in Alaska. And we're working with tribal programs to implement hepatitis C screening in rural communities and treatment by telemedicine. And our goal is to reach the HCV elimination targets in the state of Alaska by 2030. Thank you very much.
Thank you so much, Dr. Mann. This is really fascinating to hear all the great efforts you're doing in Alaska. We have a few questions that have come up, so maybe we can answer. One of them is, did you investigate or collect reasons for the high dropout in the outcome study?
Oh, well, the first study, we only had interferon available. I think if any of you have treated people with interferon, it's a horrible drug and makes them very sick. And that's why they dropped out. Most of them didn't want it. But since we've used DAA, if a patient says, I want to take DAA, we've had less than 5% dropout. The problem is a lot of people are still doing risky behavior and they don't want to come in and get treated, or it's really hard to find them. And so that's one of the efforts that we're doing right now, is to try to track them down with the patient navigator and get them to start treatment and figure out unique ways to get them to finish their DAA treatment. But no problem with DAA. It's miraculous drugs with minimal side effects, as everyone on this webinar knows, with a very high sustained virologic response rate.
Thank you. Yeah, I think some of the things that you discussed about having a community health worker or having access to treatment through telemedicine, that kind of resonates with the populations that we are interested in. We have another question. Have you had any issues with medical associations pushing back on allowed CHAs to conduct this type of service for patients? I know DHTs were similar, and ADA pushed back on allowing them to deliver certain services.
Not in Alaska, we haven't had any problem. The other thing that's really unique, we don't usually get pharmaceutical companies to give us free medications, unless, and the only way we can get medicines for other diseases like diabetes, for example, is through Medicare, Medicaid, or private insurance. And then our systems get some money from the government. It's not enough to cover all the patient care, but that money can be used to buy drugs. But the two companies that make the DAAs are giving the drugs for free to us as long as someone doesn't qualify for Medicare or Medicaid. And so we can treat everybody.
Okay, thank you, Dr. Mann. This is great. We will continue with addressing the other questions during our discussion session. Let's move on to our next speaker, Dr. Jennifer Price, and she's an associate professor of medicine at the Division of Gastroenterology and Hepatology at the University of California, San Francisco School of Medicine. She's also the director of the UCSF Viral Hepatitis Center. The title of her talk is No One Waits, Community-Based Approaches to HCV Elimination in San Francisco. Dr. Price, take it away.
Great, thank you. Thank you so much for inviting me to give this talk. I'm really happy to be here. I wanted to start with providing some context surrounding the work that I will be presenting. So in San Francisco, we estimate over 11,000 people are living with active untreated hepatitis C. And an estimated 90% of these are people who inject drugs, which by contrast, people who inject drugs make up only about 3% of the total population in San Francisco. So in 2016, San Francisco became the first US city to launch a hepatitis C elimination initiative, and we call this End Hep CSF. And End Hep CSF is really a community-owned collective impact initiative, and it's comprised of a real diversity of partners and stakeholders, all with a shared mission to support all San Franciscans living with and at risk for hepatitis C. There are 5 pillars of collective impact models that I've listed here, and you can see on the right how we structure our model with the various working groups. And since its inception, the group has recognized some key barriers to hepatitis C testing and treatment in San Francisco and has worked really hard to successfully execute some solutions to these barriers. In the interest of time, I won't read through all of these, but I just wanted to draw your attention to a couple of them. We've developed a really successful community peer navigation program. And then also, in addition to a lot of advocacy work from other groups, as well as End Hep CSF, successfully advocated for the removal of DAA payer restrictions in the city. So I wanted to provide that background because the work I'm going to be talking about was conducted in the context of many people working very hard to mitigate many of the systems, provider, and patient level barriers to hepatitis C care that we know helps or contribute to disparities in the care cascade. So it was in this context that we launched the No One Waits or Now study in 2020. This was a community-based point of diagnosis hepatitis C treatment study. And our primary objective was to establish the feasibility, acceptability, and effectiveness of an on-site Hep C point of diagnosis treatment model, in which we provided 2-week starter packs of sofosbuvir velpatasvir at the time of active Hep C confirmation, and then attempted to obtain the rest of the treatment course through insurance-provided medication. It's important to note that our study site was actually not a clinical site. It was a community-based site. It was the Quaker Meeting House in San Francisco, and I've shown a picture of it here. And the Quaker Meeting House is located by the Civic Center area. And we specifically chose this site because it was close to where our target population tends to congregate and was also close to public transportation. So I'm going to spend a little bit of time walking through the study design. There were basically 2 phases of consent. The first phase was consenting to hepatitis C screening. So we screened with the rapid Hep C antibody. We also did rapid HIV testing at that time, so just the finger stick. If the antibody was reactive, then we proceeded to venipuncture and sent the blood for Hep C RNA and also hepatitis B surface antigen. The participant came back the following week for their RNA disclosure. And if the RNA was positive and they met inclusion criteria for on-site rapid treatment start, they were offered enrollment in the NOW study. If they consented to enrollment, then that same day, we drew pre-treatment labs, and I've listed the pre-treatment labs here. We set up a telehealth clinician encounter, so they had a clinician encounter, and then they started that day sofosbuvir velpatasvir with a 2-week starter pack that was provided by the study. behind the scenes, then we prescribed the remainder of the treatment course and attempted to get insurance authorized medication. So here is our enrollment. We, from July of 2020 to October of 2021, we screened 490 people for hepatitis C. Exactly half were anti-Hep C antibody reactive. And among them, 111 were Hep C RNA positive and eligible to enroll in point of diagnosis hepatitis C treatment. Now, of those, 89 returned for their Hep C RNA results disclosure. And of those who returned for their disclosure, 87 elected to enroll in the treatment arm of the study. So I just want to pause here and point out a couple issues. One is that 7% of our participants who were antibody positive were unable to get confirmatory testing because we were unable to draw blood, and we had a very skilled phlebotomist. So the requirement of venipuncture for RNA confirmatory testing is still a major barrier, particularly for our patients who have a history of injection drug use. The other thing I want to point out is that we had 126 people who were RNA positive, and the majority of them were eligible for what we called a modified, simplified hepatitis C treatment algorithm. So essentially, most of the people that we were screening were eligible for simplified treatment. I've listed on this slide the reasons why the other 15 were not eligible. Also want to highlight that we lost 20% of those who were eligible in between visits 1 or 2. So anytime we have a step in the care cascade, there's the opportunity that we can lose people to follow up. But among those who did follow up for the RNA result disclosure, the vast majority, 98%, enrolled in same-day treatment. And the other 2 who declined enrollment, they really declined because they didn't want to participate in a research study, but they were successfully referred to standard of care treatment. So here's our study population. Our median age was 48, 71% were male. I want to highlight here that 61% had slept outside or in a vehicle in the past 12 months, and 43% were currently living outdoors or in a vehicle. Only a small percentage were what we would consider to be stably housed, 97% with an income below the national poverty line, and 80% had reported any injection drug use in the past 3 months. Also want to highlight that 94% were insured at the time of enrollment, which I really think speaks to our excellent safety net healthcare coverage in San Francisco. So as I mentioned, 87 people started treatment, 69 of them, so 79% completed treatment. Among those that completed treatment, 92% had an undetectable Hep C RNA at the end of treatment. And among those, 95% had confirmed SVR12. So there were 3 people who were undetected at end of treatment, who then were detected again at SVR12. And we believe that 2 of those 3 actually had a reinfection during that post-treatment follow-up period. So overall, our intention to treat SVR12 was 67, and our protocol SVR12 was 84. Important to note that we did see a lower SVR12 in people who had experienced homelessness over the past 12 months. Again, showing that homelessness is a major barrier to treatment completion and Hep C treatment success in our patients. There were no adverse events causing premature treatment discontinuation. And importantly, we did not have to make any alterations in our treatment based on those pre-treatment labs that were drawn on the day of their DAA start. So remember, we drew the pre-treatment labs before they took their first pill, but we didn't get the results back until after they had already started treatment. Now, an important component of the feasibility of the study was that we used staff-assisted telemedicine to provide Hep C treatment. We conducted a telemedicine sub-study, and 94% of the respondents thought that receiving clinical care via telemedicine was helpful. And actually, most of them, 81%, were interested in using telemedicine in the future to address another health condition. Another hugely important component of the study was the collaboration with the pharmacy team. So remember, the study was designed to give a 2-week starter pack of sofosbuvir velpatasvir, but then we provided the remainder of the treatment course through insurance-provided medication. So how did this work? I put here on this slide all of the different steps from intake to medication dispensation. as well as the team members involved and the approximate amount of time that each step took. So big picture, what you can see here is it required a lot of collaboration. There were a lot of steps, and some of the steps took a lot of time, but a variable amount of time. So for example, the benefits investigation could be as quick as 5 minutes or as long as 7 days. The insurance approval could be one day or 3 days. But we were able to successfully transition to insurance covered DAAs in 91% of participants during the 12-week course. And 77% of them transitioned after the 2-week starter pack. So that was really our goal, was after they got their starter pack to successfully transition to insurance provided medication. And we achieved that in 3/4 of the population. But 23% did still require additional study drug to prevent treatment gaps. And 9% remained on the study provided drug throughout treatment. So I've listed here some of the reasons for delay in transition to insurance covered DAAs. A few of our participants, they were insured, but their insurance was out of our network. So our clinicians couldn't prescribe at Kaiser or at the VA, for example. And there were a few people who were not insured, so we had to assist them to get insurance. But the most common reason for delay was actually that some of the contracted specialty pharmacies required oral consent with the patient to deliver their medication. And that ended up being a big barrier. So our key lessons was that collaborative teamwork with the pharmacy was needed to meet our goals. And even though we had a highly insured population, there still were insurance related barriers. And it was particularly difficult for individuals without stable housing and without a phone to receive their medications without insurance. Finally, free medication programs were really essential. So the donated study drugs filled the gaps in treatment, and we also needed copay assistance for some of the participants. Now, one of the big patient level barriers to completing treatment was actually medication security. So 63% of our survey participants reported concerns about safely storing their DAAs, and 1/3 reported missed doses due to medication loss or theft. So this led us to develop with patients medication security strategies. And I've put some examples of these here, as well as the cost. There were low cost strategies to allow participants to keep their medications on their person. So one example of this, we fashioned necklaces with a bag for each day of the week and put their pills in each bag for each day so they could take their pill, throw out the bag. We modified a fanny pack. We modified a pillbox to attach a carabiner so that the participant could loop the pillbox on his belt loop. So it was really important to our participants that they could actually hold on to their medications, because if they had it in a bag, it was at risk for being stolen or swept up in a street sweep. So key take-home points from the NOW study were that the point of diagnosis, hepatitis C treatment in the community setting, was acceptable and effective. 98% of those offered actually chose same-day treatment starts. And our SVR12 rates were similar to that in other studies in people who use drugs. And when I was thinking about what the kind of themes were for the success, I came up with a few. One of them is that we really shortened the steps from Hep C treatment diagnosis to treatment. So kind of decrease the number of chances that we could lose people to follow-up in between their diagnosis to getting started on DAAs. We got this down to a 2-step process. Obviously, we're trying to think about how we can truncate this even further to 1 step. This was community-based. It was not a clinical setting. We met people where they were, and it was important to be close to where our participants lived and congregated and close to public transit. A really important point is the staff-assisted collaboration with the medical and pharmacy team. We thought about how we could utilize the technology we had available to us in a way to address the needs of the population and really maximize the specialty resources, including our specialty pharmacy. And finally, we supported participants on treatment. We had regular check-ins, and then I talked about the safe medication storage devices. So in the last few minutes, just building on these themes, I want to talk about a couple other projects. One is our hepatitis C mobile screening and treatment van, which we call the Deliver Care Van. This actually leverages the clinical infrastructure of our UCSF hepatitis C clinic, and also requires or relies on outside funding, including funding from the San Francisco Department of Public Health, to tailor our services to people who use drugs or who are experiencing homelessness. And our model is similar to the NOW study model, but not quite as truncated. So when we first meet the client, we can perform a rapid antibody test and then conduct venipuncture for confirmatory RNA testing. They'll come back 1 week later for RNA results disclosure. If positive, we do have a portable fiber scan on the van, so we can do a fiber scan. We collect insurance information, as well as all of the clinic consent forms that you would sign, at the doctor's office. We have the client sign that on the van. The following week, we set up a staff-assisted clinician telehealth visit, draw the pre-treatment labs, and after the visit, send our prescription to the pharmacy. And then the following week, the patient gets started on treatment. So from diagnosis to treatment, we can do everything in about 3 weeks. So again, same theme, shortening the steps from diagnosis to treatment. Also, similar theme of meeting people where they are. We ask people after they've been cured how they feel about their Hep C cure. And I included just one quote from one of our patients who was successfully treated, who said, "I was touched that UCSF has come to me because I would not have been able to go to them. It was convenient to have the van outside my methadone clinic. I used to be embarrassed about my Hep C status, but now that I have treated it, I feel confident in being able to follow through with other obstacles." And then we rely very heavily on staff-assisted collaboration with the medical and pharmacy team and try to support patients as best we can on treatment. And just to provide an example of this, I took a screenshot from our outreach summary from one of our sites from last week and de-identified everything. But you can see here, there's a lot of collaboration and a lot of work that goes on behind the scenes to make sure that things move smoothly for our clients. The final example I wanted to give of addressing multiple barriers to hepatitis C care is the multi-site peer-enhanced rapid Hep C test and treat and opioid treatment programs study that is being led by Dr. Shon Vlade-Nulia from Johns Hopkins. And there's actually 2 interventions in the study. The first intervention is randomization to receive Hep C treatment within the opioid treatment program versus a standard of care referral. And the idea here is to really address the systems level and provider level barriers to hepatitis C treatment starts. And then the second intervention is a peer support intervention to try to address the patient level barriers. And this study is still enrolling, so I can't present any results, but in assessing feasibility, we conducted a survey of the clinical leadership at the 5 participating OTP sites across the US and Canada. And the leadership gave very high scores for acceptability to staff of the on-site Hep C treatment model, and also thought that it was appropriate to meeting their clients' needs and priorities. But I think it's important to point out here that they gave lower scores for feasibility. And some of their potential concerns were maintaining the momentum of Hep C treatment in the face of competing priorities, coordinating new tasks to ensure smooth workflow integration, and managing the politics and finances of a new on-site Hep C treatment program. So that kind of leads me to my final slide, lessons learned and recommendations. I think one thing to remember is that simple is not the same thing as easy. And I think the leadership survey at the OTP site is a good example of that. We can really simplify the Hep C treatment regimen, but it doesn't mean that that's simple to execute. It actually can be quite challenging to execute. And our community partners are stretched very thin. It's not necessarily easy also for our patients to take their medications every day and to be able to hold on to their medications. Community engagement and stakeholder input is really, really essential. We need to involve everybody in these programs before we implement them. I think another key take-home point is to leverage the existing expertise, infrastructure, and technology that you have. I know it's cheesy, but I always say to the staff, don't let perfect be the enemy of the good. And I think if we're trying to be perfect, we're never going to get this work done. If we demand perfect adherence to medication, we're not going to be able to treat everybody. And finally, expect the unexpected challenges and adapt to them. So I want to just thank the entire NOW study, including my incredible co-investigators, Dr. Megan Morris and Dr. Annie Lukemeyer, the entire Deliver Caravan staff, the NHEP CSF community, and all of our NOW study and rapid study participants. And thank you for your attention.
Thank you, Dr. Price. That was really very interesting and very inspiring. We have received a few questions. Let me see. One of them were the few participants who were apparently reinfected, subsequently retreated.
So they were referred, yes, for treatment for outside of the study.
And did you give the study participants cell phones to contact?
We did not give participants cell phones.
Okay. It was really interesting to see that the drugs were being stolen and you had to come up with a device for that. I think that's really fascinating to see some of the challenges that these patients are facing. We will move on to our next speaker and come back to the questions later on. Our next speaker is Dr. Bertha Flores. She is the Associate Professor of Nursing at the School of Nursing at the University of Texas Health Science Center, San Antonio. As a practicing women's healthcare nurse practitioner, she has acquired a unique perspective of the needs of women. And today she's going to present to us on Stop HCV, HCV, a community-based approach to integrate HCV screening and treatment in rural primary care. Dr. Flores, you can take it away.
Thank you. Thank you for having me today. I appreciate the opportunity to present today our program, which is Stop HCV. Today, what I'll talk about a little bit is about how our program was implemented and how we help to decrease some of those barriers. Just to tell you a little bit first about the program, this is a multi-level, multifaceted approach. We provide counseling, evaluate, and treat for hepatitis C in 4 clinics, systems, or 28 clinics throughout South Texas. South Texas, we also include different components, including medical records modifications. We have an app, we have a website, and the main thing we do for those patients who are uninsured, we have teleconsultation hours. And we have also developed a website, which I'll talk a little bit about more in a few minutes. This is the map of Texas, and we are right here in South Texas. This South Texas is a 36 county area, primarily with a minority Hispanic population. One of the things we do for in the program is education, and we have education for clinicians, for staff, community health workers, community, and patients. And so, for example, some of the education we provide is for providers and staff. We do this in several ways. We have webinars, we have face-to-face presentations, and they're also available in the website so people can take them on their own time. So these are just some of the examples of the education that we have put together. We have found out that education does show improved HCV knowledge and attitudes among providers and staff. We have also developed short infographics that providers and clinicians can take a quick look. And so this is also a sample of some of the informatics and handouts that we have produced. For community and patients, we also have provided a website. We have testimonials. If you go to the website, for example, we have patient testimonials. All the programs that we developed were with community input. All our community education, including leaflets, they are all in English and Spanish, and they all have been with community input. So for example, just to let you know a little bit about the community input when we were developing the website, some people thought that some of the information was too long or the testimonials were too long. And we used that information to shorten the information. So everything we have done is with community input. Here is just an example of some of the information that is available to the community. All the leaflets are also developed with 6th grade or lower reading level. Again, they are in English and in Spanish, and developed with community input. The other thing we developed is an app. So for example, all the clinics that we work with, of course, this is a tool to provide additional education. Again, it is in English and in Spanish, and it was developed with community input. But the providers can use this as an additional tool to provide information to the newly diagnosed. And we are working together right now to put this on the App Store. So that's the next step. But for right now, we have all the clinics have tablets where when the patient comes in, they can use this as an additional tool. And it also helps decrease the technological divide, for example. So all the clinics have access to the tablets and the app. And like I mentioned earlier, we have a website. The website is the stophepatitisc.com. And that is, again, we have information for clinicians, we have information for the public. The other thing we have is Hepatitis C Echo. And this Echo, it's usually about an hour. We usually have experts, and people can join from many parts of Texas to join this ECHO program. So some of the things that we talk about is how to decrease barriers. So as you know, the guidelines now are implemented to screen all adults for HCV. However, there's not necessarily a primary care model. We also suffer from physician shortages, for example. You can see specialists 1 to 456, gastroenterologist is 1 to 28,000, and then infectious diseases is even higher. They also have some other unique challenges here in our population, which are primarily low-income minority populations. Lack of insurance coverage, for example, stigma, lack of knowledge, poor access to specialty care, and also transportation, for example, to come to a big center. I think similar to how our first presenter was talking about Alaska, we have a lot of rural communities, and lack of transportation is an issue. And of course, the cost and availability of the DAAs. So some of the ways that we help decrease or eliminate these barriers, for example, is we have navigation, and the navigation helps patients obtain the DAAs through the Pharmaceutical Assistance Program. And we have been very successful. And again, how the presenters mentioned previously, these are for the uninsured. If they have insurance, then Medicare or Medicaid can cover those costs or other type of insurance. We also use a teleconsultation model, which is different than the ECHO. And I'll talk a little bit more about that next. For example, also some of our screening criteria originally, as was recommended, was for all baby boomers. Later on, we added for people who have at least 2 abnormal ALTs. And then now, of course, we include all patients per new screening guidelines. Now, for those that are uninsured, then they can participate in the STOP HCV program. If they agree to participate on the program, of course, then it's the assistance with the navigation, assistance with the medications, all the labs are covered, all the ultrasound is covered as well. And so far, we have screened over 32,000 patients in Texas for hepatitis C. We have, 1,600 patients confirmed. with HCV infection. We have referrals to specialists and also help the PCPs treat the patients in their clinics. We use the teleconsultation model. This is individualized management. Usually we arrange these consults during the lunch hour where most clinicians are available in between patients, so it's convenient. Usually takes about 10 minutes. They present the patient and the hepatologist then provides the recommendations. They present information on the labs, any imaging, some demographic factors, medications, comorbidities, etc. And then they have an individualized plan. And then the PCP also can ask additional questions, and also the PCPs are learning how to treat HCV in their own clinic. This is some of our workflow, for example, that you can see those that are identified and then can be followed up with education and labs, education including the app, schedule the teleconsultation, applications for those that are uninsured for the DAAs, start the treatment. There's a 4-week optional follow-up, end of treatment, and then the 12-week labs, and all the way to cured. So the teleconsultation office hours, for example, are in 4 clinic systems in South Texas and the Rio Grande Valley. We have 87 consultation calls attended by 28 providers, 32 case navigators, and we have managed plans for at least 314 uninsured patients. And of course, this is an ever-changing number. For example, next week we have 4 teleconsultations scheduled already. And this is how the care cascade can look like. And again, this is ever-changing. And there's always, of course, a lag because there's a 12 weeks SVR. But we have been successful. There is some loss to follow up, but the percentage is small. But there is some patients that are lost to follow up for many different reasons. I like to thank then, of course, all our wonderful team that helps us and all our partners. Thank you very much.
Thank you, Dr. Flores. That is amazing. Thank you for sharing your results from this Stop HCV program, and really happy to see that you have resources available for healthcare providers on the educational materials. So I don't see any specific questions. Let me quickly check. I don't see anything. Oh yeah, there is one. Is this part of the TECH program with Baylor Group in Texas?
No, this is, we have separate funding with cancer prevention. And then also we have a P30 NIH grant.
Thank you. So with that, I will turn it over to Dr. Ward, who's going to manage the discussion with our panelists.
Thank you very much, Rena, and great presentations. Keep the comments and questions coming in. We have 2 excellent panelists. We're going to start with Dr. Amy Kraviatz, who's Chief Physician of statewide HIV, hepatitis, and renal transplant programs for the California Correctional Healthcare Services. Amy, please provide some perspectives. Thank you.
Hello, thank you for having me today. I'm going to talk about our HCV treatment programs in California state prisons. And we we're very big program, very big prison system. We started in around 2017 with the more momentum for DAAs that were launched globally. And in 2017, at that time, we had 35 facilities and a population of about 132,000 patients, of whom 18,000 patients were RNA positive and needed treatment. So this was a daunting task, and as with most infectious disease programs, you can't do much without screening and testing. So in 2016, the hepatitis C was added to the reception center intake lab opt-out screening panel. And our rates for screening with the opt-out are very high, from 90 to 97%. Believe it or not, in 2017, we did not have an electronic medical record. And so we had a massive rollout to our 35 institutions to finally come online. And 2018, we realized seeing patients one at a time really wasn't going to get the job done. So a central team was created to manage the entire treatment cascade. And 2019, we started having electronic tools that were really monumental in getting the job done in terms of registries, electronic forms, tracking and monitoring. And we also realized that our little central team was never going to be able to treat 18,000 patients. And so we began a hub and spoke model where we trained all the PCPs at all the institutions, and the primary care physicians started to treat hepatitis C. In 2021, we had a slowdown along with everybody else, but despite that, we had the ramp up very dramatically, actually, for our medically assisted treatment program during that time. And our focus in 2023 has been to continue ramping that up. That has also gone to a hub and spoke model for the primary care physicians being able to treat all the patients. And we are now starting a cognitive behavioral therapy rollout. And our plans for 2024 are to continue to expand access to substance use disorder treatment, which of course is the root cause of all of this. So this is just briefly to kind of show you the transition from where we were and where we are. So from 2017 to now, we now only have 33 prisons, and our population has gone down to about 97,000. Our entering antibody positivity rate through the reception centers is about the same, though, at 17 to 22%. And our prevalence in the whole population of HCV antibody positivity has also remained the same, from 20 to 25%. Our active RNA positivity in our population has gone down from 14% to 4%. And that is despite an incoming arrivals of 3,000 a month, about 36,000 a year to begin with, and now at about 2,200. Which is 26,000 yearly, and that's with a pretty sustained incoming RNA positivity rate of 12%. And so our eligible patients to treat, starting with the 18,000, is now at 3,700. The access model went, as we mentioned, from individual treatment to the PCP and central headquarters hybrid model. And the patients completing treatment, it was really about 780 in 2017, has gone from 3,000 to a peak of 9,000 during the intervening years. And so in terms of patients that we have yet to offer treatment, there's only about 1,000 left. And our total number of patients that we've treated is at 33,437. None of this really matters, of course, if we don't address substance use disorder. And so we had this massive program that I was telling you about. And so you can see these numbers are very impressive. 95,000 patients screened, 37,000 patients assessed for their treatment needs, 24,000 plus evaluated for medical assisted treatment, and 16,000 actually provided MAT, and behavioral therapy started, and SUD treatment actually provided of any type in 22,704 patients. And our epidemiologist, Kim Lucas, who runs a lot of our epidemiology for us for hepatitis C, did some studies and was able to show that patients on MAT had a 33% reduction in HCV reinfections, and it was also associated with an increased SVR rate. So our program now, as you can see, we're pretty green. This is very high screening rates, very high annual retesting rate, very high timely treatment. Our SVR is on par with the community, and our ability to obtain an SVR test is high. Our substance use disorder screening is on the way up. I expect this to be in the 80s in a few months. And our reinfection rate started when we started our dashboard in, I believe, 2021, was at 6%, and now we're down to 4%. And that's all I have. Thank you.
Well, that's a lot. So thank you very much for going over that so quickly. It's a fantastic program. We have very few model programs in correctional settings in the US, and this is certainly one of them. So thank you for giving us the highlights of that. Again, please have your comments and questions coming in. Let me turn to Julius. We can go over to his slide for his introduction. Julius Wilder is a hepatologist at Duke University. He's vice chair of the American Association for Study of Liver Disease Public Policy Committee, and has written several perspectives about health disparities in there and hepatitis elimination. So Julius, over to you.
Great, thank you very much. Happy to be here and honored to have the opportunity to participate in this important conversation. In the interest of time, I don't have slides, but I've been asked to come and speak to this idea of us being on the precipice of an amazing feat. We are actually at a point in time, and John certainly knows this as he's been the person leading this important discussion, is around actually moving forward towards hepatitis C eradication in the US. This, of course, being driven for the first time at the highest level of leadership in our country from the White House. You all may know that the Biden-Harris administration included in recent budgets that were proposals that were submitted, a proposed 5-year program to eliminate hepatitis C in the US. This program, importantly, was developed through extensive consultations with key stakeholders within and outside government, including patient groups, physician groups, and federal agencies. What I'd like to do in a little bit of time I have here is just sort of speak to the 3 main priorities around this, because a lot of these priorities, quite frankly, speak directly to the point of this seminar, right? The idea of understanding the importance of health equity and access, and speaks to the very types of programs and incredible work that the people are doing in this space that we've talked about today. So one of the first priorities is going to be around testing. How do we do our diagnostic testing? Funds will be look to be used to leverage point of care hepatitis C RNA diagnostic tests. In the US, we are somewhat behind the rest of the world in this space. But being able to sort of develop that program here in the US, leveraging the Independent Technology Assessment Program, which is a collaboration between the Food and Drug Administration and the NIH to speed up clearance and approval of these point of care RNA testing, will allow us to really be able to do the types of screens that we need to be doing, primarily single visit screens that then will allow us to provide treatment and move forward. And honestly, when we think about trying to engage those communities at greatest risk, those underserved communities, having this type of technology available to us will be key in us being successful in moving forward towards screening as we think about eradication. A second priority for this program will be around how do we think about the model, right, for getting these medications? How are we going to pay for this? And a key element will be a national subscription model to purchase these direct-acting antivirals for those who are particularly underserved, right? So, and this is where I love the idea, because we're really thinking about health equity now, right? And that's what we've talked about today, right? Who are those at greatest risk? And we think about health equity, that's not about being equal, right? That's about making sure that we prioritize resources into those spaces where there is greatest need, right? And so a national subscription program that recognizes the importance of ensuring access for Medicaid beneficiaries, justice-involved populations, people without insurance, the American Indian, Alaska Native individuals who are treated through the Indian Health Service, prioritizing those types of populations through a subscription model will be of great benefit moving us towards elimination and eradication of hepatitis C, particularly the fact that not only will that make these medications more affordable and improve access, but it's a win-win because we know that our partners in the industry will benefit from the volume in terms of purchase medications. And so we're excited about the idea of leveraging similar programs that have been successful in the VA, as well as been successful in Louisiana to move forward towards eradication. The third major sort of piece to this proposal is around a really comprehensive public health effort to engage, inform, identify, and treat people with hepatitis C. And Dr. Price has spoken to this, and Dr. McMahon spoke to this, and Dr. Flores spoke to this. They've all sort of talked about, right, the importance of not just being in our health systems or just sort of making these sort of decisions and writing prescriptions, but actually engaging the community, understanding from the community through a true community-based participatory research approach. What is the best way to test? What is the best way to screen? What is the best way for us to think about how we actually engage and develop these programs? Knowing that may vary depending upon, where people are, who people are, and the various factors impacting their access to healthcare. So universal screening, build an infrastructure for treatment, innovative models of treatment such as mobile units, community-based clinics, as well as vaccine development will all be part of that third piece. So we're very excited about this plan and the potential opportunity for us to actually do something that's very, very unique and special, given the burden of this disease and how it really harms lives, right, in terms of liver cancer, cirrhosis, and we actually can do it with a plan like this, given the strength of the medications we have to cure hepatitis C. So I'll stop there and take any questions you all have. Thank you.
Thank you, Julius. See if there's any questions specifically for you. Not as yet. We did have.
We can ask the speakers to come on camera.
Yeah, everybody go on camera. And Julius, I know, and Amy, you may have some questions for the speakers. So let me get the round robin discussion going by Julius. Ask the question that came to mind for you as you heard the presentations.
I'm sorry, John, you said it again. I didn't hear that.
Okay, just I thought just to get the discussion going among all the speakers, I thought maybe you had a question that came to mind for you as you heard the presentations that you would like to pose at this time for their comment.
So absolutely, yeah. I mean, I'd love to hear from some of the presenters about, because you all work in unique populations, unique communities, and you've built tremendous trust and engagement in these communities. And I'd love to hear from you about how you did that. And when we think about hepatitis C eradication, the best way to do that. So that we can actually, create impactful and sustainable programs in those spaces around hepatitis C eradication. Perhaps Dr. Price, the incredible work you've done, you can kind of speak about how you've done that.
Yeah, thank you. I mean, I think we've done so that was place just started and started mobile.
Dr. Price, we are having trouble hearing you.
Oh dear. Is that? Can you hear me now?
It's better. Try. I think you're cutting out, but try again. Try again.
Let me hold on. I'm going to disconnect my VPN.
Oh, that's better. That's better.
Oh, that's better. Okay.
Go ahead.
Sorry, something weird happens with my Zoom when I mute. So what I was saying was that I could not have done this work without the NTEP CSF. Having that initiative together, one of the roles of the group is to really make these connections, introduce people like me, who's I'm a transplant hepatologist, to people in the community. I sat in on the prevention linkage and linkage working group to find out what the gaps were, where we needed extra work. When I outfitted our mobile van, I really relied very heavily on NTEP CSF to help guide me, to tell me where we should go, and also to train us how to do the rapid test. We don't do rapid antibody tests in the hepatitis clinic, right, in our regular clinic. So I think having those connections and just being open-minded, everybody was very supportive and collaborative.
Thank you. Amy, do you have a question, please?
Yes, I think it would be difficult to say who I would be interested in anybody's talking about this, but I feel like we're chasing our tail with hepatitis C. I mean, we're all focused on treatment, but without, can we do this without completely integrating global access to clean needles, without substance use disorder treatment, without really combining these two efforts? Are we going to be able to get the job done? And how would we maybe approach some discussions around smoking as opposed to injecting?
Well, that's great. I think it'll be difficult to treat our way out of this problem in the U.S. Be interesting to hear, Jennifer. And also, just from the program in Texas, we didn't hear a lot about harm reduction, access to clean needles, or perhaps I am not recalling it at the moment, but perhaps we could get a perspective from that program as well. And then, of course, Brian had a very low reinfection rate, and be interesting to see what's the status of harm reduction for people who inject drugs in Alaska. So let's go around the table on that one, please. Jennifer, please start.
Okay, yeah, so we do have access to clean needles in San Francisco. We do a lot of harm reduction counseling. This is I think a critical question, a critical issue. I agree. We've also had more of our deliver caravan patients who have died of overdose than died of a Hep C related complication. So, trying to get people access to MAT, like you mentioned, making sure people have access to clean needles is a huge priority. And we have a new navigation coordinator on the van he's developed educational programs on harm reduction, which we're doing monthly now to our patient population. But I agree, it's critical importance.
Okay, thank you. Bertha?
Yeah, so we do not specifically do the, how you mentioned, the clean needles, but there's many other programs who do in our community. However, all the PCPs usually do send the patients through mental health services or any other services that the patient may need.
What is the status of access to drug treatment in Texas for, let's say, Medicaid patients?
So they can get treatment. That's the first thing we actually do. We try to get them through Medicaid, but it's the ones that, for whatever reason, don't qualify, then we do the PAPs.
Mm-hmm.
Mm-hmm.
So you
yes,
refer-
but that is yes. So our navigators, which is they do a wonderful job because they'll assist the patients in filling out all the forms and helping them through the process.
Thank you.
And that's where the navigation, I think it's a great help.
Okay, thank you. Brian, please give us an update on what the status of the issue of injection drug use in Alaska, hepatitis C in that population, and how you're seeking to address it for the Native American community, Alaskan Native community.
Thanks, John. Well, unfortunately, the state legislature, which is a bit on the conservative side in Alaska, has not really passed a bill to be able to distribute clean needles. And our needle exchange program in town, which is open to anybody, runs out of needles all the time. And so that's something we really need to solve. And the other thing that's really difficult is that we realized that during the COVID epidemic, the cartels more or less got into some of the rural villages, and there's a lot of injection drug use in certain communities. For example, the first 83 persons that we screened in the rural villages, 13 of them were HCV RNA positive. And so that's quite high. Now that probably targeted, the community health aid practitioners targeted people who they knew were injecting drugs. but that's quite scary. And how do we get clean needles out to the villages? We have to get our tribal leaders to agree to doing that. I might mention one thing that pertains to a question that was asked. If you're an American Indian or Alaskan Native, your tribal organization can either get their funding and program through the Indian Health Service with all the restrictions, and or they can become independent. Now, our organizations in Alaska are taken over by the tribes and run by the tribes. They get some funding from the Indian Health Service, but they have to obtain the rest of it from Medicare, Medicaid, et cetera. It's easier to work with tribally run programs than it is, I think, in general. However, the Indian Health Service is really aggressively has webinars or meetings every month or two, trying to work together globally through the U.S. to try to increase screening and treatment. So they're working hard on it. But I think the issue of clean needles is really one that really we have to address everywhere and make this. We need some legislation, both national and statewide legislation, to make it easier and get funding for clean needles, I think.
Thank you. Thank you very much. Any other comments on that? I thought I heard someone. The other thing, oh, sorry, go ahead. Is that Rena?
I was just going to follow up on Amy's presentation, where she talked about when you're doing HCV screening, you're also trying to screen for substance use disorder. I think those two probably can be implemented, or think about implementing them when you're doing screening in all these settings. Is that being done routinely, or is that something one has to think about implementing?
Is your question for me or for the speakers?
Anyone can answer that. It prompted me to think about from your presentation.
Yeah, it's easier for us because we know that the incoming substance use disorder rate is very, very high. And so global screening for substance use disorder, it's happening along with and independently of HCV screening. But personally, I think that that is the way to go because it's the root cause. And so to start, we're trying to work on shortening our ability to get treatment, in as few appointments as possible, right? But we also might want to hit the door running with substance use disorder, or we're just, again, going to get reinfections. And so if we can get them plugged in very early on, I love this mobile clinic idea that Dr. Price mentioned, add the substance use to the mobile van, whatever it takes. But again, as she mentioned, it's all hands on deck.
Yeah, I would add to that, building off of the really great point Amy just made, is in the general hepatology clinics, I don't know that we are doing really intense screening for substance abuse the way we should, not globally. And it speaks to the benefit of what has been done, and some of the speakers have spoken to this idea of clinics that are really devoted to hepatitis C. And you can leverage in those settings multidisciplinary clinics where you have individuals and specialists there who can help navigate that conversation, provide appropriate resources, connect to care and so forth, and linkage to care moving forward in that setting. And that probably is going to be an important discussion for a number of health systems that treat large population hepatitis C to think about building as part of that infrastructure, to think about how we can truly do what Amy's doing, which is address this issue of chasing our tail with substance abuse and hep C, screening and treatment.
Thank you.
Yeah, if I could add in something about that. We do screen for substance abuse in the liver clinics, but most of that are going on in persons that don't get to liver clinic until they've got liver disease. But the other thing I think is important is screening for alcohol. And we use the audit C, which only takes 30 seconds. And our aides hand that to the patient. And then by the time we walk into the room, that's filled out. And that is really crucial because in addition to curing hepatitis C, if we don't address other issues that affect a person's liver, including alcohol and NAFLD, and address that, we're going to make good progress, but we're not going to make complete progress and save patients from needing to go for a liver transplant if they develop liver failure afterwards.
No, thank you, Brian. And it makes me think of the slide of the definition of disparities that we had in front of us to kick off this webinar. And it really, it brings to mind this conversation here at the end. We have a major disparity in access to prevention for those who are injecting drugs or abusing others, overusing other substances like alcohol, as Brian mentioned. And we really, have to be fully aware of this huge overlap of both of these epidemics and how they're feeding the HCV incidence, and we have to pay attention to that. Our collaborators at NIDA have had several webinars on this topic as part of this series, so I encourage you to go and get more information about that. But that's a lot of work needs to be done in that area to turn off the faucet of new infections as we seek to reduce prevalence through testing and treatment. And lastly, what else this webinar brings to mind for me is the importance of champions for hepatitis elimination. I think you've seen an excellent example of champions and what can be brought together through coalitions that the champion is a part of, either leading or participating in, but really having that champion to really put programs together, energize partners, and really make progress possible that would not have been possible otherwise. And I just want to thank all the presenters for their work on that. And thanks to panelists, Julius and Amy, for their work also. I think we have an evaluation that we'd like for you to fill out to make sure this webinar is as effective as possible, and look forward to your suggestions on that. Also want to let everyone know we have a photo contest of hepatitis elimination in action, so that we can have images that are often more compelling than words for many people. I think we have a slide about that. There's a QR code that you can go to get more information about that. So all the programs are on the call today. Please share your photo contest. I want to thank my colleague here at the Coalition, Lindsay Hebert, for her production of this webinar. And I'll turn it over to Rena to say farewell.
Thank you, John. I want to thank the speakers. I think one of the things that we all know that we have treatment available, we have screening tests available, but it's not reaching our communities. So this is just to shine light on this problem and figure out various ways outside the box solutions to reach those populations and make this HCV elimination a real priority for all of us who are working with these communities. So I want to thank all of you for your great work, and hopefully we can continue to implement these lessons learned from your studies into other communities that need help. And I'd like to thank the planning committee from NIMHD and from your group at the task force. And thank you for all the audience for your questions. And we look forward to this presentation again next year. Thank you, everybody.
Thank
Thank
you.
Thank you. Great job, everyone. Enjoyed seeing everyone. Great presentations. Thank you so much. Keep in touch.